Well, thanks so much to all who are here. Thanks for being here. Thank you for taking time out of your morning to come spend time with us at this amazing conference. It's my first year to be at this conference. I've been in touch with Dr. Paul for some time, talking about ways that we can work together, and it just happened to be that this was the year that we could make it work. So thanks to all of you, and of course thanks to the organizers of M3. My talk is Bonded Through Service, exploring synergies between academic and faith-based organizations in global health. So for full disclosure, my background is in academics, and so I've never actually spoken at a faith-based conference before. So I'm a bit of a fish out of water. I've spoken at a lot of conferences, but if last night's session is anything like today, then I think it's going to be a really wonderful morning. So the reason I chose this topic is because my introduction into work with faith-based organizations started when I moved to Africa back in 2009, and I'll get into that in just a minute. But since that time, I've developed a very deep appreciation and respect for the work that is done. And as a secularist Jewish person of sort of faith, I have been more than welcomed into the faith-based community, and I want to take some time in this talk to share my experiences with you. So I have no disclosures, no conflicts of interest, and I of course want to thank Dr. Osteen for inviting me to address you today, and also to Sandra Harris and to my friend Jeremy, my new friend Jeremy, who has escorted me around the conference, which I never thought I needed, but you never know you need help until it's there. I'm an educator, so I'm going to give you objectives. I want to spend a little time because maybe let me just poll everybody here. How many of you have worked in missions in the past? Fantastic. All around the world, I imagine. How many of you are clinicians of some kind in the health professions? Wonderful. And how many of you are based at universities? All right. And how many of you are based at churches or other faith-based organizations? Fantastic. I think that the time is now for us to be working together in a much deeper way. And I think that both for people who are planning to do global health work or those who are already engaged, I think it's always useful to sort of go back up to the 25,000-foot view and take a look at kind of what's happening in the world as far as global trends that we are all a part of. Because I think that no matter where we're coming from, we're all actually trying to achieve the same goal, which is to improve health. So I want to talk about the evolution of the global burden of disease and its impact on these health systems that we all want to work in that are very fragile. I believe very deeply that if you're going to go work in the field, you should know a little something about the health system you're going to go into. And many times we're going into these situations that are very challenging. And so I want to talk about what all is happening at the very high level. And I want to talk about the relationship between mission work and the global distribution of human resources for health, because it is in fact that work that you are doing by going out of the field, by taking time out of your lives to dedicate to mission or service work. You are, in a way, addressing this crisis of human resources for health. So I'm going to talk a little bit about that. And I apologize for my laryngitis. It came right on time. When the speaker last night was talking about Jesus having a plan, there's a challenge here. He picked the wrong person for public engagement, but I'm going to try to do a good job like she asked us to do. And then I want to talk a little bit about short-term trips because I work in a program where I send medical students mostly, but students from all professions, I send them around the world. And this is something that as an academic I contend with and I grapple with on a daily basis, is how do I prepare these students for this work? How do I help them to humble themselves within the setting of a partnership? And I think that there are some things that we do for students that are good. And there are things that you do preparing your missionaries that you do that are also good, and we can probably learn from each other. And then I want to talk I have a few ideas on a framework, what it might look like for academic and faith-based organizations to work together. So I revised this because I realized that I had prepared I prepared a lot of diagrams in my talks. I don't want to scare you. There are going to be some graphs and some heat maps and things like that. I have like flows of 80s Egypti, and they're all very fancy. But I feel like it's important to personalize this. I was raised in a house that looks a lot like this. Many of you know this sort of thing, in upper middle class house, Jewish family. I came up well. I never came up wanting for anything. And then when I was a medical student, actually when I was an undergrad, Dr. Steve Spann, who's going to be speaking at the plenary today, organized me to go for my first trip to Argentina. It was Buenos Aires. I didn't see much difference. It was a really wonderful place to work. But then when I was a medical student, I was really called to go to medical school by a desire to serve communities. And I took an opportunity to go down to the Rio Grande Valley, down to the colonias, right near Brownsville. And I was just amazed at what I saw, which were houses that looked like this. So here was sort of what my house would look like. And then there were people within my country, in this same country that we all live in, that were living in these conditions. And I said, this is something I feel like I need to do something about. But I wasn't ready yet. I had to go to residency and do internal medicine, and then I had to move to Botswana. So it's not the Rio Grande Valley. It's a little bit different. So Botswana is located in the southern part of Africa. You can see it's a landlocked country. It's bordered by South Africa, Namibia, Zambia, and Zimbabwe. It's 85% desert, so water is scarce. In fact, the name of the currency is the Setswana word for water, which is pula. So you spend pula because money, the value of water is so high value that it is the name of the currency. And I worked in a place that looked a little like this. So I went from my high-tech internal medicine residency program out to work in a ward that looked a lot like this. And for those of you who have worked in Africa, this is not anything that is very surprising to you. Very crowded wards, many people in there at the lunch hour, full of families buzzing around. And I would also go out to very rural areas. And as I was doing all of this, I found myself really feeling very good about decisions to engage in global service work. And when I decided to come back to the US, I was asked to come and direct a program to send students around the world. And so that's what I do. And having lived in Africa and having experienced having students come visit me and seeing how much there was that they needed to know before they came, it really helped me prepare a curriculum for our students in Galveston that I think hopefully teaches them a few of the things I think they need to know before they go and insinuate themselves into other parts of the world. Not only knowledge, right? Because many people, if you've grown up in mostly in the state of Texas, we don't always know about all of these diseases and all of these conditions and the health system challenges of other countries. You also, if you haven't traveled, which many of our students have never been out of Texas, so to say nothing of going to Kenya. So how do we prepare them for that culture shock? How do we prepare them for that sort of thing? And how do we put them to use? Because I've always felt that those students have so much energy and they want to give so badly, they want to be a part of something, but they're so early in their training. What can they do? So what we do is we involve them with our work with our partners in stuff that they want them to do. So we listen to what the folks in the field want and we involve our students there. So you can see here, this is a student that's doing research. He was asked to do research. It wasn't my idea that he went and did research. It was the partner's idea. This is a student doing some service in an orphanage in Kenya. She was asked to be there to come and spend time with those kids and give them love and give them attention. And these are students participating in a field epidemiology course where they're going out and learning about how to do epidemiology work. So that's the type of work I do now. I want to launch right into the 25,000 foot view. The world is changing, and it's pretty exciting. So I always show these things. These are mortality changes. So whenever we think about countries like resource-limited countries, low and middle-income countries, we think, these are the people, they're dying from malaria, they're dying from tuberculosis, they're dying from HIV/AIDS. But in fact, over the last 20 to 30 years, we are seeing a profound shift. No longer are those the diseases that are affecting only those countries. In fact, ischemic heart disease, stroke, lung diseases are the leading killers, even in the poorest of countries. Okay, so it's not that they don't have the malaria and they don't have the TB and they don't have the other infectious diseases, but we're actually doing a pretty good job, right? That means that vaccinations are working, kids are living longer, the water is getting clean, and that means that kids can live past their 5th birthday and then into adulthood, and then they can die from ischemic heart disease just like the rest of us. Okay, so if you look at the trends, that we're seeing a lot of increases in death from ischemic heart disease and stroke, and decreases diarrheal disease, things like road injuries. So if you've traveled, you know that you've probably traveled on the road. You've probably seen 6 people to a motorbike. And so the fact that road injury deaths are going up probably is not surprising if you've traveled outside of here. So epidemiologists and global health people will describe the morbidity of disease. So we always think about mortality, that kills you, right? But that not everything kills you makes you stronger. Some of it makes you weaker. It disables you. So disability is actually how we measure disease burden, all right? And so if you look at the world, I think it's fascinating. So if you look at, on this axis, you have the disability. So how many years of productive life do people lose because of a particular disease or condition? So and then how many people die from it? So something like low back pain, which I'm just speaking with a physical therapist in the crowd. Low back pain is a pandemic across the world. It accounts for a lot of disability, right? And so physical therapists, occupational therapists are desperately needed in global health work. It doesn't kill people, but it disables them, and that's not good either. But if you look up here, high blood pressure, smoking, ischemic heart diseases, both account for high disability and high death. So it takes us all the way to here, to lower respiratory infections, to get to the first infectious disease. So if you didn't know it before, I wanna kind of work that out of your brain, that if I do global health work, I'm only gonna be treating people with infectious diseases. No, not true. In fact, you may be seeing people with heart disease and diabetes and obesity. Those of us who travel and work in other countries, we're just amazed. We think, well, I thought everybody is skinny outside of our country, but no, it's not true. So if we look at the trends from 1990, and this is data from 2012 or 2010, you can see that certain things have shifted around. It used to be that the leading causes of morbidity across the world, leading causes of disability, were lower respiratory infections, diarrhea, preterm birth complications, all of these, these infectious, thought to be only the diseases of poor countries. But now the burden of disease is much more shifted around. It's much more mixed. Ischemic heart disease is number 1. Lower respiratory infections is number 2. We go down, we get to road injuries. We get to mental health problems, major depressive disorder. In fact, the World Health Organization has predicted, based off of older data, but still pretty much validated, that the leading cause of morbidity in the world by 2030 is actually going to be unipolar depression, if you can believe that. So depression, mental health issues. I'll share a story. I'm a musician as well, and when I lived in Africa, I played music. And I knew a drummer, very, very talented drummer. This guy is brilliant. So I get a call 2 weeks ago from him, and he is just on and on and on and on. He can't stop. He's just tangential. And I said, Leroy, I think you need to get some help, buddy. And he says, no, I'm okay. Next thing I know, he's inpatient at a mental institution. The mental health is so heavily stigmatized that his mother showed up with 4 pastors and basically said, no, we're gonna take you out and we're gonna pray for you, right? And so this is one of those opportunities, I think, where we all need to engage. We need to say, okay, prayer is important. Prayer is crucial, but so is medicine. Medicine is also very important. So he was diagnosed as bipolar 1, and now he's been released from hospital, too prematurely. So when I hear stories like that, I'm not surprised by these statistics. And certainly practicing in those settings, even if you're on a short-term trip, it doesn't take you much time to realize some people are in fact depressed. So epidemiologists will call this an epidemiologic transition. So this is one of those scary graphs. I'm starting easy, it's just an X1. But it's, when people talk about epidemiologic transition, they're talking about mortality. So in early stages of a country's economic development, maybe people are hunter-gatherers, or they live in a place where there's not clean water, there's not sanitation. And the mortality rate from the communicable diseases like pneumonia and diarrhea is very high. They're losing kids under the age of 5 because of those diseases. So very high mortality rate from infectious diseases, and people aren't living long enough to get chronic diseases. But as we invest in infrastructure, in public health interventions, as we improve the roads, as we improve water, as we improve health facilities, we vaccinate, we let women deliver in safe facilities, then now all of a sudden people are living longer. And they, as I said, they get to develop all the lifestyle-related diseases that all the rest of us do. And the rate of death from communicable diseases going down. So that's the world, but people will say now that it's complicated by the triple threat. The things that don't care about the borders, the things that don't care about where you are. Pandemics. How many of us knew of the Ebola cases that came to Texas? When the Ebola cases came to Texas in 2014, I believe it was, in Dallas, we had a group from Kenya visiting our university, and they said to us, Dr. Dacso, you won't believe it, but my friends, they told me not to go to Texas because they said Ebola is there. So they cautioned us not to come to Texas because you guys have Ebola. They were coming from Kenya. So pandemics are a real deal. That contributes significantly to the burden of disease. Globalization, economic globalization, the interactions between trade and wealth are profound, and they're very important for us to understand, those of us who want to go into the field and do meaningful work. And then climate change. Very important topic, not often discussed in our setting, okay? It's just sort of a taboo subject. But it's extremely important. It is affecting the environments of the people we want to go and serve. They are now no longer able to grow the crops that they want to grow to be able to sustain their lives and livelihoods. So they're all having to move to cities, and they can't find jobs, so they migrate here. Violence begets violence, and people are forced out, and they migrate. Humans are animals. We migrate when conditions are not appropriate for life. So all of those are related and cross-cutting. This is a map of Aedes aegypti. How many of you have heard of that mosquito? So that is the mosquito that transmits things like chikungunya virus and dengue and Zika. So this is a map of kind of where you're most likely to find that mosquito. And then this is a group of folks that did predictions of where you're most likely to find that mosquito up until the year 2070. So I won't make you read the whole thing, but I prepared this lecture, or this slide when I was giving a talk in Canada. I was asked to come and talk about vector-borne disease. I was asked to come talk about mosquitoes and ticks and all the diseases they cause. And I said, why do the Canadians want to hear about this stuff? We know mosquitoes down here, all right? I know mosquitoes. I'm from Texas. I live on the Gulf Coast. I know mosquitoes. What are you guys talking about? Well, when I started researching it, I was amazed to find that, in fact, we are expecting that by 2040, between 2041 and 2070, Aedes aegypti will be able to survive winter in Canada, right? So that is telling us that things are changing. Who knows why? We can debate that till the cows come home, but we know it's changing, and so it's affecting health. So all of those people that we want to go and serve and take care of, this is the context. So the other part that I think is crucial for us to understand is the human resources. So the WHO did a beautiful study about just over 10 years ago. Their World Health Report was called Working Together for Health. And they did a big assessment of what's the situation, right? What's the situation? Those of us who have traveled and have worked, we go to these countries and we say, where are all the nurses and the doctors? Why are there not enough? Why are there, just like the physician yesterday was describing the line of 500 people lined out of his clinic. How many of you, I know we hate waiting, but how many of you had to wait it for 3 weeks to go see a physician? Nobody, right? We don't have that. So, well, there's about 60 million health workers worldwide, and when they don't account for health professions here, they're accounting for doctors, nurses, and midwives. And about 57 countries are in a state of crisis. That means there are fewer than 23 health workers per 10,000. So imagine that, fewer than 23 per 10,000. There are more than 23 health workers in my little area of UTMB Galveston Hospital, okay? Just in my little floor, my half of the floor, right? So think about the scale of which we're talking about. That little half of my floor now expected to care for 10,000 people. I complain because my patient panel is we complain when our patient panels get up to 800. So about 27% of the world's burden of disease, as I mentioned, the disability, is in sub-Saharan Africa, but only 3% of the world's healthcare workers are in that continent. Compare with the Americas region, which is including North and South America. 10% of the world's burden of disease is in our region, but we have over a third of all of the health workers in that region. And what that looks like is this. This is what distribution of health workers looks like across the world. So we see in gray, high density of health workers and low mortality. Okay, so overall low mortality rates. Now we start getting into the global south, and it's much different, right? So the darker color is the lower density of health workers, higher mortality. And so you can see that we are not distributed well across the world. So what I implore everybody who's thinking about doing global work to think about is, well, what's our goal here? I think our goal is that everybody should be gray, right? Shouldn't that be our goal, right? I think our goal is that we work ourselves out of a job. Someday, it would be great if I didn't have to go and do the things that I do because there's someone better than me, right? There are already many people way better than me at this work. But folks in the field who are doing this work, who are from those countries, we don't need to have this inequity. So we should be working to restore equity. So why does this happen? Well, about 20% of people in rich countries, so that's the OECD countries, the rich countries, about 20% of those are from abroad. So we actually are not blameless here. And I'm talking from US and European perspectives. We do a lot of recruitment in poor countries to get health workers from those countries to come and work in our settings because we have health worker shortages, right? How many of you guys have heard we have a primary care shortage in Texas? Where do you think we're looking for doctors, right? We're going to other countries. Less so in these days than in previous years, but that's the idea. So when you look at the statistics, a small country that doesn't have a lot of population, doesn't have a lot of health workers, are affected greatly. And if you look at this, I was speaking to a number of folks that do mission work in Haiti. Do you know that Haiti exports sometimes up to half of its doctors, right, and health workers? So we are seeing countries that are beneficiaries of mission work that are exporting their own doctors. Tanzania's on that list, Angola, Sierra Leone. Sierra Leone just went through one of the biggest Ebola crises. And you'll find a whole bunch of Sierra Leone, you wanna see a Sierra Leone doctor, you can go to London, okay? So, so this is the crisis that we're in, is that in a way, as people who want to go and serve the world's poor, we are filling a gap, but the gap is left by a system problem, right? And there's a system problem that people have tried to measure. They call it push factors and pull factors. So why are people not being retained in their home countries? Well, when the WHO studied this, they found that people said that in those they felt like in the places they were pulled to, it was better remuneration. They were paid better. It was a safer environment. The living conditions were better. But there were also things in their home countries that pushed them out. Lack of facilities, lack of promotion, no future. Having lived and worked in sub-Saharan Africa, I can tell you, having worked in a residency program, trying to retain these guys who are just asking me, hey, if you go back to the States, can you see if you can find me a job? I said, no, I need you here. I've worked so hard to train you. Why don't you want to stay? And it's because of these things. I say, honestly, like I can't take care of people if we're running out of normal saline. It's too frustrating, right? So I am feeling pushed out by these factors that are health system problems, and I'm feeling attracted to come and work in your environment where you don't have to worry about normal saline. Does that make sense? So this is the state of affairs. So United Nations in 2000 came up with these things called the Millennium Development Goals. Have you heard of those? Yeah, so the MDGs. So they set these very audacious goals, 8 of them, and those goals were designed to basically get the world together and say we should all work together to achieve these 8 goals. They were audacious. They had very ambitious metrics. And it was really the first time that the world came together and said, yeah, this is what we think is needed. And it was things like, reduce poverty, keep women healthy during childbirth, keep kids alive, fight communicable diseases like HIV. Unfortunately, by 2015, we'd had conflicts, we'd had all of these unanticipated things, and in fact, none of the goals were achieved. So they went back to the drawing board and they came up with 17 of them. They said, what we need is more goals. Those goals weren't really enough. These are more goals. And they, what was nice about these is they gave us goals to look for, not just big picture ones like reducing inequalities. They said, here is what that means. So if you notice, there's only one that's dedicated to health specifically. But if you read into each of these, health finds its way through all of the goals. So that's giving us something, whether we're on the faith-based side or academic side, these are giving us something to sort of hang ourselves on and say, all right, I'm working on partnerships for the goals. And so here are the things that I can do to deliver on that goal. And here's the things I should report to deliver on that goal. So an example, that the health-related goal is SDG 3. It says by 2030. So we gave ourselves another 15 years. The cost is about $24 trillion. So we'll see. I'm going to ask the guy from Mercy Ships to see if he can help us fundraise because he seems to be really good at it. But look, these are actually like on pen and paper numbers that we should say, all right, countries can work towards achieving these goals. Reducing global maternal mortality to under 70% for 100,000. Ending preventable deaths of newborns. Ending epidemics of AIDS, TB, malaria, and communicable diseases. But it also has things that are the more system things I talked about. Substance abuse, tobacco, intellectual property rights. Okay, pharmaceutical industry makes a lot of money. Okay, a lot of money on pharmaceuticals, and they protect the patents, and they don't like for countries to make generics. All right, so there's always debates in the WHO about what to do about pharmaceutical pricing. So that's addressed in the goals. Health financing, health workforce, all are in there. So these are pretty big goals. Now, people feel depressed when I tell them that we didn't achieve the goals. But let me just do a little experiment. So the WHO defines health as a state of complete physical, social, and mental well-being, and not just the absence of disease. Complete physical, social, and mental well-being, and not the absence of disease. So raise your hands if you're healthy. Right, complete. Right, so I'm always joking with the students that, man, when you guys get ready for that test, how's your mental health? You stressed? All right, not healthy that day. And then maybe you go and you get a bunch of Whataburger afterwards, and you say, I'm just gonna pound Whataburger because I haven't eaten in 4 days. How's your physical health, right? And so health is, as defined, is a goal. It's an aspirational goal. So if we move the needle by trying to achieve these goals, we've done something, right? So goals are really set. We can set them far so that we can try to achieve them. And if we move that in a direction, we've done something good. All right, so it's okay to be audacious. So that's my context. So there's a lot of debate around what we do, both in what I do, in my work, sending students around the world, and in churches, sending missionaries across the world. And I want to dig down on that a little bit, because I think that on both sides, there's probably Global health is a very critical field. We're very critical of ourselves. We don't often take a moment to sit back, rest on our laurels and say, we're doing a great job. And we don't get a lot of external validation because people are always criticizing us for all the work that we're doing. And probably missionaries feel the same way. But I want to give an objective look. This is a non-critical look at medical missions, both short-term and long-term, on the secular or academic side and on the faith-based side. So there's something that when I teach global health, I think we have to own. And I tell them we own this as people who work in the field, people who come from a rich country, who come from a resource-rich place that is a political, international political giant that can throw its weight around however it wants. That's the setting that we come from. And we go to work in places where they don't have that type of power, global power. And that was structural. Does anybody know who this guy is? You can't answer it. Anybody know who this is? Yeah, that's Cecil Rhodes. So what was Cecil Rhodes famous for? Yeah. So Cecil Rhodes, so I show this I will tell you that I've never had one medical student identify this person correctly. They always think it's Hitler because he's got the little mustache. So it's not Hitler. Hitler didn't do anything. Why would Hitler be standing on Africa? So as you can see, Cecil Rhodes has 1 foot in Cape Town and he has 1 foot in Cairo and he's holding a wire. So he had this dream, right? He was a British colonial power and he believed vehemently that the African continent needed to be civilized. He believed it deeply that it needed to be brought faith, it needed to be brought economic development, it needed to be brought culture, they needed to stop the polygamy, they needed to stop all of these behaviors because it was not civilized. And he believed deeply that it was the role of the British to do that, okay? And so, but he was also a smart financial person and he invested and he was a part of corporate expansion into Africa. So he also saw a huge benefit for the UK should they establish colonies in Africa to be able to extract things and to be able to bring them to the UK to make the UK better and stronger because that's what they needed. They needed guidance, right? And it was that mentality that shaped the colonial enterprise for 100 years, right? And so generations of people in the continent of Africa grew up under colonial rule. And that's the legacy. That all fell apart after World War II, very rapid decolonization of Africa, very rapid borders were drawn, communities were grouped together, leaders were put into place, flags were given, national anthem was given, go. Right, very fast. It took hundreds of years to build a colonial enterprise, and in very few years, very short time, it was gone. So, so that's Cecil Rhodes. And he's only one example. Right? Other countries did the same thing, but that's our legacy. When I teach about global health to our students, I say that's what we have to own. When we are not greeted and received with open arms as saviors, it's because people know. They've seen people like us come in with open arms and look what happens, right? So that trust must be earned, right? It must be earned through time and effort and hard work. And to be truthful and to be fair, those colonial things, those are still around. We have things like the World Trade Organization, the World Bank, IMF, that for better or for worse have shaped financial policy, global financial policy for the last 50, 60 years. And those policies have not always benefited Africa, and they've not always benefited poor countries. They've actually sometimes been structured to benefit us, right? So some people have said that even what we do now is just colonialism by a different name, right? So we're walking into that. We're tiptoeing into that as people who want to serve, right? We're tiptoeing into that context. So that's just for me to say, that's not to say, all right, well, there's nothing to be done, I'm out. No, it's just that we have to be reflective about it and we have to own that if we actually want to move forward from it. So what does it look like? What does volunteerism look like? Well, estimated, again, numbers are hard to get. Not everybody is great at reporting their numbers, but about 1.6 million volunteer tourists. So that comes from the faith-based side and the secular side, all right? But a lot of volunteer tourists. So volunteerism is a big industry. $2 billion at least is probably a conservative estimate. I've seen up to $4 billion per year spent on mission trips, all right, and on short-term trips. Billion with a B, okay? So to give you an idea of how many times you can buy and sell Haiti's GDP, all right, it's several times over with that number. There are about 500 organizations that spend $250 million a year, so bigger organization.
Is that each or is that
Total. Oh no, yeah, yes, that's each. And then about 84% of the world's population is religiously affiliated. So when I first started thinking about the intersections of academic work and faith-based work, I didn't know how many people in the world identified with a religion. So what this means is that all of the critiques that come about evangelism while going on mission trips and things like that, many times people who are being proselytized to are actually have already converted in many cases. So many people are already declared in a religion. It's a big industry. So I started looking around. You can buy your mission trip t-shirts. So there's a whole industry that's cropped up around short-term missions to feed the demand. And wouldn't you? I mean, if I were just a venture capitalist, I would look at a $2 billion industry and say, I'm gonna try to get in on that, right? So there is a big industry around it. There's also increased interest among academics. About 1 in every 3 medical students participates in an international elective during medical school. So we know that the students, the youth, are just so interested in this type of work. They want to get out in the field. They want to do something. They demand these global health experiences. They want to do research. They want to have something they want to participate in something that has global impact. And what that's resulted in is a lot of universities, because they want to respond to these students, they want to get the best students, right? Universities are just like any business. We're competing for those great students. And universities want to get those great students. They say, hey, look, you can go to Africa. Look, you can go to Peru. We'll send you there, right? You can go and see stuff you've never seen before. So we do that. We are guilty, all right? We are complicit in that narrative as well. And that's driven a lot of us to develop academic partnership. A lot of universities, they say, well, let's go to Kenya because we're gonna say we wanna help them, but really it's because we wanna send our students, right? Or because we wanna do research. Recognizing this, people have started to think about it and say, well, if you're gonna go out and you're gonna create a relationship in another country, maybe there are some guidelines you should follow. Maybe there's some things that we should try to bring to these relationships. Maybe it shouldn't be all extraction. Maybe it should be something that is more of a collaboration. So these guys convened a very big group that was from people from all continents, and they tried to come up with some guidelines about what we should do. And they were really speaking to academics, but it was really anybody who's gonna send a trainee or a younger person into the field. What are the responsibilities? They said that they needed to be focused on mutual benefit, all right? So that it couldn't just be all for the trainee, it also had to be for the partner. They said that local partners needed to be involved in any kind of planning, that there need to be clear goals. You shouldn't just go out and say, hey, let's do some stuff, and I'm gonna send you some students, and they're gonna go out and take care of patients. Not good, not ethical, not allowed. And they made recommendations for both sending and host institutions, trainees, and sponsors of the work. So it was really the first time that anybody had tried to really condense all of this angst, existential angst about short-term work into one document. So as we've, both on my side and on faith-based sides, there've been a number, I was telling someone when I walked in, as I was preparing for this talk, I've written some papers on this, but then in, over the last 3-4 years, the number of manuscripts has exploded. So that means there's lots of interest. But in general, people center on the challenges in the field. So what's the scope of work of the people that are going? How are they supervised? Who's benefiting from those trips, all right? We have to make sure that the people who are inviting us into their communities are the ones who are the beneficiaries. What's the impact? What can you hope to do in a week, right? What can you hope to do in a month? What can you hope to do in a year, right? What is the impact? Are those trips taking place under the rubric of a larger partnership? Very important topics that people are debating and figuring out. How much burden is it placing? When I send a student into the field and I go into a hospital, maybe they don't speak the language. Are they going to be asking a nurse to help them translate? That's taking the nurse away from her job so that she can help my US student, take a history or practice something. We have to think about that as people who are organizing those trips. And then the power dynamics. So this is not just for what they do, but how do we prepare them, right? When they show up in a ward and they are a foreigner and they are asked, hey, can you pay for my son's x-ray because we don't have money? How do we help them grapple with that personal responsibility, but the power dynamic just by them being in that setting, what is happening, how that has disrupted the ecosystem. So I want to finish briefly with what I think are some opportunities or ways forward. I think that we have to balance our values and our motivations. So I'm not saying this is to be cynical. This is just from my review of what has been written about the topic and many years of working with both faith-based and academic institutions, what I think are what we're balancing. So on the academic side, we're balancing our student opportunities, research, the opportunity to publish, to get promoted, to get tenure, all of those things that academics covet, right? We are covetous beings, so that's what we want, right? And the university, there are some universities that truly have a service mission for global health, but many want the prestige. They want to be listed in the list of people that are institutions that do it so that they can feed the cycle. On the faith-based side, there's the evangelical directive, all right? There is the service ministry that is inherent in so many faith-based organizations. There's volunteerism, and most importantly, there's youth engagement. It's almost like if you don't do a mission trip, people are going to ask, well, why aren't we doing a mission trip, right? So there are those motivations. But I think where we really, really are aligned and really should focus is we are all here to improve health. We are all here to address inequity. The reason we're doing this, the reason anybody is at this conference, I imagine, is because you see some inequity in the world and you say, what can I do about it? I want to do something, right? So you want to address the inequity. How we do it, that's a debate, but we all want to do it. And we want to advocate. Whether we're advocating on the faith-based side or the academic side, we want to advocate for the poor and for those that are disenfranchised and the people who are trying to serve. So what can we learn from one another? I think on the academic side, there are things we're good at and there are things we're not good at. There are the things we're good at. We're good at research. Actually, academic institutions are very good at doing this and measuring outcomes and designing studies. When I've worked with faith-based organizations, some of them have never measured what the impact of what they do. I say, let's help with that. Let us help with that, because that's something we can do. Dissemination of your stuff, so publishing, right? People should learn from what you do. They should crave your knowledge and your experience. We also do a good job of preparation. Academic institutions are training institutions, so we're good at teaching people how to teach, teaching people how to learn. And the other thing, not to be coarse, but travel safety. Because universities are very they're very risk averse. They make students and everybody jump through all these hoops. So we have 8 layers of legal paperwork and documentation, and then every student has to fill out 9 papers that say that you're not going to sue the university if you get malaria. So we're pretty good at that stuff. But what have I learned personally from faith-based institutions? I think faith-based institutions are extremely good at philanthropy. They know how to deliver their message. They know how to mobilize the people to understand the reason that what they do. Academics, we show you heat maps and charts, and we're like, look, it's important. And they're like, I'm not really sure. Where's the story? Where's the hook? So I think faith-based institutions are much better at that. I was watching the Mercy Ships thing yesterday and I said, why am I crying? A beautiful video that they showed, and they do. Faith-based institutions do such a better job. Their long-term commitment. So I've had the privilege to come to meet a number of missionaries that have made the determination that their call is to serve in Africa, and they live there, and they do such a better job. They live in the community. They don't live in some compound like we did when I lived in Botswana, right? They live in the community. They eat and pray and sweat and bleed with the members of the community in a way that I think we have a lot to learn from. I think that the long-term missionaries get very well prepared. I've had the opportunity to speak with a number of missionaries about the training that they had to do before they were allowed to go into the field. It was a year. They had to move to one place for a year and be trained in language, in ethnography, in culture, in how to learn about those things and how to integrate and how to deal with these challenges. They do such a better job because they're so deeply committed. And then relationship-based partnerships, that faith-based organizations dedicate themselves to a community and they stay, no matter what. It gets violent, they don't leave, right? Academic institutions in Kenya, every time Al-Shabaab decides to do something in a mall, there's 10 emails that I have to respond to. Where's our students? Are we gonna pull them out? Missionaries don't do that. They say, we're here for the long haul. And I think we can learn from that. We've had some experience working with faith-based institutions. These are just a summary of a few of them. We've worked with the Maua Methodist Hospital in Kenya. We've helped them do some hospital-based quality improvement work. We've actually, one of our PhD public health faculty has helped develop a whole community-based program around improving the health of street-involved youth, so street kids. He is actually a pastor turned public health specialist. We've worked with Kijabi Hospital, and that is where our internal medicine residents go for their rotations. And then we've worked with Nyachibale Hospital in Uganda on various surgical quality improvement studies, and then some outcomes impact evaluation. So we've worked with hospitals that work with African Mission Healthcare. You heard Mark and Rabbi Erica talking last night about their work. We actually have worked to send our students to do evaluations of the investments that they have made in those hospitals, so that those hospitals can say, look what we did. Your investment decreased surgical complications, improved mortality, helped our moms deliver in a safer place. So we think those were some productive things. In the interest of time, I'm gonna skip these points, but I want you to know that there was a very beautiful series of papers that The Lancet published about 4 years ago, and they were basically talking about what we can do. How can faith-based institutions partner with public health, and what did we need to learn from each other? How did public health institutions need to learn how to understand and appreciate the role of faith-based organizations and what motivates faith-based organizations? Similarly, what did faith-based organizations have to do? I want to highlight just the last one, right? And because I feel like this one summarizes what I've felt for now so many years working in the field. We don't want to use religious teaching to undermine evidence-informed public health practice, nor do we want to use secularist ideology to undermine the work of faith-based group in health. So there's a mutual respect, right, that I think we have to work hard to articulate. The framework I came up with is derived from a couple that have been published. I think the things that we can really hinge ourselves on are shared mission. So working with our partners on developing shared mission. What is our goal here? What do we want to see? What's the nature of the partnership? How do we prepare people to go into the field? How do we help people to reflect on the work that they do so that it helps them improve themselves and improve the work they do? How do we support it? How do we fundraise? How do we keep this thing sustainable? Because so many of the projects that we end up part of in academics are funded by grants, and those grants end after 5 years, and then we're stuck looking for more grants, right? So how do we sustain that work? Faith-based organizations in many ways have figured that out. And then how do we evaluate the work that we do? And I think really it's the evaluation piece where academics and faith-based organizations can start working. At least in my experience, that's what we've done in Galveston, and I think it's been successful. Those are centered on the 3 principles of humility, respect, and transparency. So that means that we humble ourselves in the work that we do, not just before our deity, but before the people that we're there to serve. So we're not there to do anything to them. We're there to assist when asked and to humble ourselves to their knowledge, to respect, and then to be transparent about it all. I finish with 3 Old Testament concepts that I think, because it's a missions conference, I wanted to talk about the Old Testament. So there are 3 things that were impactful for me growing up Jewish, 3 concepts. One is tzedakah, which probably you've heard of that concept. It's called tzedakah. It's charity or giving, but it actually comes from the word tzedek in Hebrew, which means justice. So the idea of giving is not just to give so that you feel good. It's because you believe in restorative justice, that because there is inequity, you're there to help restore it. Gemilut Chasidim is paying back loyalty to other human beings. So it's not just giving money, it's giving of your time and of your effort and of your body and your soul. So it's dedicating time more than anything. Not just because you want to see things improve, but as payback for you being able to do what you do. So when I told you my story at the beginning, part of the reason I do what I do is because somehow I feel like I have to use my position, right? I was given privilege. I was given certain things. I didn't have a choice of where I was born, but I have choice of what I do with my time. And then the last is tikkun olam. Tikkun olam is that we have a drive to fix or repair the world, right? So that's something that's Old Testament. That's something that we must embrace, both for academics and on the faith-based side. And if you want a good read, it's 7 Hebrew words and phrases every activist should know. That's where I found that. So thank you guys for letting me talk to you and address you today. I hope it was interesting for you. I think there's just a few minutes for a couple of questions, and that's my talk. Thank you guys so much for being here.
Does anybody have a question they'd like to? Go ahead, yes, ma'am.
So you talked about publishing work, and it's something that's come up among academics that are in emerging countries that they sometimes feel like they don't get the same opportunities to publish. So they've done the majority of the work, but then it gets published under another country, another person's name. Do you have any recommendations for those who maybe don't have the connections or already have a PhD or whatever else to be able to get published for work that they've done in their own countries?
That's awesome. Thank you for that. The question was about publication. So first of all, I'm so glad you brought that up because that was some of the earliest experience I had when I was in Botswana. I was there and I said, man, we look at this really interesting problem. Let's publish it. And my partners, my Botswana colleagues said, whoa. Why do you want to publish? All of a sudden, I'd gone from being a partner and someone who was working with them and alongside them and to wait a minute, because they had that exact thing happen. They'd worked hard on a project and then in comes a university and they basically say, thank you for this work. We'll take your data. We're going to go back to the US. We're going to process it and we're going to publish in the journals that you don't have access to because you're across the Atlantic and they charge subscription fees. So what are some ways to do it? Well, I think partnership is probably, first of all, I'll say that is now making its way out of the university behavior. There's a number of people who have brought a lot of focus on that. There are people who've published papers on authorship. So what percentage of papers about malaria in Africa include Africans? And it's appalling. Right? There was a while where it was under a quarter. It was 20, 25%. What should you think about the number of people who are writing? That means that they were just taking. They were not doing any giving. So I think partnership with, if there's partnership with an academic institution that's possible, that has to be demanded. I think certainly from my experience, when I was even just asking very politely, oh, can we write this up? It was very, whoa, who's gonna lead? Who's gonna do it? Because they'd been burned a couple times. And so I think those are important conversations, and so many times they get rolled over. So if you have a position to advocate for that partner to be involved, I think that's the key. So I think partnership with academics. And then there are open access journals that actively solicit input and publications from resource limited settings. There are also regional journals that are often have an easier bar to be able to get published, and more of those are getting indexed to be able to get referenced. So those are the places I'd start.
Since you send residents to faith-based hospitals, what do you say, or how do you get their buy-in if they're not coming from a faith-based perspective to want to go to a setting like that? Because I work in academics and I have a hand in some of the global health activity that we do, and sometimes when I talk to my colleagues who don't have a faith base, I told them about this conference, they're like, whoa, I don't want to go to a Christian conference. But I'm like, no, it's a global health conference.
Yeah.
So how do you get them? How do you get your colleagues or your residents to buy into that idea of there is mutual benefit?
It's a tough one, right? It's a tough question. I will say that many of our students and even the residents, when I talk to them, they are actually sort of called to do the work by faith. So the ones that want to go, it's sort of like they're comfortable with it because that's really why they're going anyway. I have had instances, because where we send them to Kijabi actually has a statement of faith. So a resident, before rotating there, has to sign that they understand it's a faith-based institution, and they have to actually sign that, that there is that there's a statement of an understanding that of faith, and that they are agreeing to it. So really, I tell the students that if they don't jive with that, then we have to send them somewhere else. So we're lucky and privileged to have other places we can send students that don't fit that mold. Residents, we don't have as many. If they are going to be uncomfortable in a faith-based institution for whatever reason, then they probably is not going to be a good fit for them to go. But part of that is like orienting them to like, well, this is, up to, depending on your statistics, between 10 and 60% of healthcare is delivered at this level. So treat it as an opportunity to learn.